Hi, everybody. Just give us a moment as people enter the platform and then we'll get started. Okay, well, people are still entering the platform, but I'm going to go ahead and get started, and they can catch up as they roll in. So, hello. Thank you all so much for joining us today for the third briefing in a series featuring leading scientists, organization directors, former federal agency officials, practitioners, and people with lived experience to explore the pivotal role of federal funding for addiction science and the prevention and treatment of substance use disorders. As you see here, I'm Diana Fishbein, otherwise known as Denny. This series of 6 to 7 webinars is designed to clearly link rigorous addiction research with the real-world policy decisions that shape prevention, treatment, and recovery outcomes across the United States. This third installment, Connecting Addiction Science to Public Health Policy, will make clear that evidence-based research must guide public health policy, particularly at the federal level, where investment decisions determine whether effective, equitable, and sustainable interventions and services reach states, communities, and individuals who need them most. Here are the sponsors of this briefing: the National Prevention Science Coalition to Improve Lives, the first organization in the United States to systematically translate prevention science to public health policy, and our partner, the Addiction Science Defense Network. The ASDN was formed to urge policymakers to preserve the funding for research and the evidence-based programs that are so critically needed. We provide for an exchange of information and an action platform for individuals, organizations, and governments that study, prevent, and treat problems caused by psychoactive substance use and other addictive behaviors. This is just a snapshot of a page from our website showing the sorts of opportunities that we offer. I want to mention the impact report. Over the course of the last few months, we've conducted a scoping analysis of the current landscape of addiction policy and its implications for public health and safety. This report will be released towards the end of March, and all of you will receive a notification. I also want to announce our next briefing in this series, The Promise of Prevention, a topic very dear to my own heart. It will be on April 12th from 2 to 3:30 Eastern Time. I know you probably won't have time to scan this QR code, but I will show this again towards the end. Here are our experts that will be speaking today. Each one of them will be introduced just before their talk. So I'm not going to introduce them here, but they will be introduced very briefly. Please see the website for their full bios. And finally, housekeeping. Go ahead, feel free to message each other in the chat. Panelists won't be able to see them. We won't be able to track them. They go by so quickly, but we can review them later. We review the chat later to see if there are any important links or resources that you would like us to have. If you have questions for the speakers, please put them into the Q&A and we'll address them as we can, either right after a talk end of the session where we have a goodly amount of time to receive your questions. Also, please know that the recording and resources will appear on our website a few days after the briefing, and you will automatically receive a link so that you can view them or share them. Now, I want to introduce our co-moderator. Paige Marsland is a postdoctoral researcher at Binghamton University, where her work focuses on understanding how adolescent alcohol exposure shapes neural circuit function across the lifespan. In addition to her bench research, she's the founder of Bite Size Neuro. You should look it up. It's extremely cool. It's a volunteer science communication initiative dedicated to increasing science literacy in schools and community organizations. Complex neuroscience concepts are translated into accessible content for general audiences, with a particular focus on engaging students in scientific thinking and an inspiring interest in research and science. But first, before Paige begins to introduce the speakers, I want to introduce Rob Vincent. Rob is a United States Navy Desert Storm veteran and senior public sector executive with 38 years of leadership across education, behavioral health, and federal policy. As the Associate Administrator for Alcohol Prevention and Treatment Policy at SAMHSA, he provided national leadership on alcohol policy, interagency coordination, and evidence-based prevention and treatment strategies. And he will be giving opening remarks. Thank you, Rob.
Well, good morning if you're on the West Coast, and good afternoon if you're on the East Coast. And thank you for joining us today. I want to begin by just recognizing the Addiction Science Defense Network. Really, it is this community that has consistently stood up for scientific integrity and protected the role of research in public decision making. What this group does is not just essential to health and well-being and to our communities, and I really couldn't be prouder to be part of it. Evidence-based policymaking rests on really a simple truth. When we use data, research, and real-world outcomes to guide decisions, we make better choices. When we invest our public dollars more wisely, it is certainly more helpful for all and achieves better outcomes. We design programs that actually work, and that we build systems that learn and improve over time. That matters because the challenges in front of us are really urgent. Alcohol, tobacco, and other psychoactive substances and other behavioral health addictions account for a significant share of morbidity and mortality in the United States. These are major drivers of chronic disease, overdose deaths, accidents, injuries. And while the harms are serious, they're not inevitable. They're shaped by the environments that people live in, environments that public health policy can change. For more than 50 years, research has shown that well-designed policies can reduce availability, reshape commercial influence, and drive down population-level substance use. Most of what we know about epidemic substance use, its patterns, its consequences, and what works to prevent it comes from federally funded research. That research has helped us build programs and policies that improve life expectancy and strengthen communities by grounding action in evidence rather than ideology. Pardon me. Science helps us understand complexity. It shows how housing stability, economic opportunity, community safety, and access to care intersect with commercial forces that influence availability, marketing, and consumption of addictive products. And in a moment when information moves faster than ever, science helps us separate signal from noise so we can act with clarity instead of speculation. We've all seen what happens when decisions are made without evidence. Ineffective programs, wasted resources, communities left with the same problems year after year. But we've also seen the opposite, how outcomes improve when prevention strategies are grounded in research, when treatment approaches are evaluated and refined, and when policymakers have access to transparent, high-quality data. Evidence doesn't eliminate uncertainty, but it certainly does reduce it. It doesn't guarantee perfection, but it dramatically increases the likelihood of our efforts will succeed. It strengthens the public trust. And when we see that decisions are rooted in science, confidence is instilled and our institutions grow. So the question isn't whether we can solve the challenges ahead. It's whether we'll choose to use the best available tools, rigorous science, transparent data, and a commitment to continuous learning. The urgency is real. The stakes are pretty high right now, and the path forward is very clear. And with that, I'd really just like to say thank you to this esteemed panel, because that brings us to our next conversation. And with that, let me turn it over to Paige for our next introduction.
Thank you so much. And thank you for the wonderful opening remarks. So first up, we have Dr. King. Dr. King holds a PhD in epidemiology from the State University of New York at Buffalo and has spent over 20 years translating tobacco science into policy. He most recently served as director of the Center for Tobacco Products at the FDA, and prior to that as deputy director for research translation in the Office on Smoking and Health at the CDC. Dr. King had served as senior associate editor on multiple U.S. Surgeon General's reports on tobacco and was lead author of CDC's evidence-based guide, Best Practices for Comprehensive Tobacco Control Programs. Please welcome Dr. King.
Excellent. Thank you, Paige. Appreciate the introduction and appreciate the opportunity to speak with you all today. So as was noted, I am with the Campaign for Tobacco-Free Kids, which is the leading advocacy organization for tobacco control, both domestically and abroad. But we also do a variety of other health-related work through the Global Health Advocacy Incubator as well. That said, a crux of the work that we do is translating data into actionable policy and advocacy. And so this is a really stellar conversation today. And glad that tobacco is part of that discussion. And that's important because tobacco use remains the leading cause of preventable disease and death in this country. And it's a result of that science over nearly a century, documenting what those health risks are, but also how much they cost society. And this slide shows that really a massive cost on society. Nearly 500,000 deaths continue to occur in the United States from cigarette smoking alone. That's 30 million Americans. And we also have 5.6 million children today who will die prematurely because of smoking. And so that also reinforces the importance of prevention and prevention science. But it's not only the health risks. We also know that it costs society a considerable amount of money, upwards of $600 billion a year. That's billion with a B, including 240 billion per year in direct healthcare costs, but also nearly 400 million in lost productivity. And a sizable portion of these are paid for by government-funded programs, and so taxpayers and others. And so ultimately, it behooves us to implement evidence-based tobacco control efforts to obviously save lives and prevent tobacco-related disease and death, but also to save significant societal costs that could otherwise be spent elsewhere. That said, the science has driven us to know what the risks are, which is important for informing policy, but it's also driven awareness and knowledge of what policies and interventions work best, not only to prevent an on-ramp of new users of these products, but also to facilitate an off-ramp in terms of cessation to help people quit. And so this bell curve shows how far we've come, which I would consider, one of the greatest public health achievements of the past century is the marked declines we've seen in cigarette smoking. And so you can see here that things were upticking up until about the mid 60s. And then what happened in the mid 1960s? It was the first U.S. Surgeon General's report acknowledging the link of smoking to cancer. And since that time, we've had 35 Surgeon General's reports documenting other health risks as well. But it was that first evidence-based compendium of information that was leveraged by a federal entity to then inform the public and also inform the implementation of policies. And since that time, you've seen that through a variety of levers, whether that be broadcast ad bans on television, cigarette taxes, and master a settlement agreement in the late 1990s, which prohibited the way in which these products can be advertised and reach kids. And then more recently, you've seen FDA get the authority to regulate tobacco products in 2009. And again, all part of a continued process to use the science to inform effective policy as well as regulation. And so just to give people a little flavor of how much science is out there, when it comes to tobacco, we have, as I said, nearly a century's worth of science. And that's a good thing. And it can also be used to translate it to other risk factors, some of which you'll hear later about today. But we have a lot of entities scientifically to assess this, including the Institute of Medicine, the Surgeon General, which has now released 35 comprehensive reports on a variety of different topics over more than a half century. You have the National Cancer Institute that has issued multiple monographs, and then also the National Academies, who has issued reports. And these important comprehensive bodies of literatures are really important. And so we need individual science as well, but ultimately looking at that full scope of all the evidence is really helpful to contextualize, to inform decision makers at the local, state, and national level. And indeed, that's been the bread and butter and hallmark of tobacco control now for over a half century. And so when we think about what are the policies that are most effective, this is what I like to call the tobacco control vaccine. It's actually published in the literature. I authored it with a colleague of mine, Amanda Kong. And so we call it the King Kong article due to our last names. But just to put it in a way that you can understand, we have these evidence-based interventions that we know if we inoculate the population with them and implement them, it's going to prevent tobacco-related disease and death, and most importantly, use. And so you see some of those on the side, including increasing the price of tobacco products, which is the single most effective intervention to reduce consumption, implementing smoke-free policies that protect people from secondhand smoke, but also prevent people from starting and help facilitate people to quit. Hard-hitting mass media campaigns that educate the public about the risk of these products and help prevent kids from starting and help adults to quit and get to resources, including quit lines, and also importantly, cessation resources. As I noted, we've got 30 million adults in this country that still smoke, and so there's still a need to make sure that they have evidence-based resources to help them quit using safe and effective mechanisms. But there's also the vaccine booster with a variety of other new policies. And again, so we know what works, but there's also opportunity for continued innovation and implementation of policies to help continue to move that lever forward to help prevent and reduce tobacco use. And just to show you some examples, at least at the ecologic level, about the impact. So as I noted, price is one of the single most effective interventions to reduce consumption of tobacco product. And here you just see that link. The states that have the highest taxes on cigarettes have the lowest prevalence of use. And that is no coincidence. And we know that implementing these policies, whether that be at the local, state, or federal level, when implemented, we see reductions in use of these products. And so again, just one example that you see visually, that when these policies are implemented, we know they work. And it was that science that drove us to understand this, but also to evaluate them as well. And when it comes to this research to action, the paradigm is really threefold. We need the science to inform the development of policies back when they, first initially are conceived, and then to implement them and make sure that we're implementing and getting the intended targets and not having adverse unintended effects. And then we also have to evaluate as well, because the marketplace continues to change. You want to make sure that you have that intended effect and also avoiding unintended effect. And so across the paradigm, regardless of the policy you're talking about, that science is that common thread that helps drive to effectuate change. And that can be implemented at multiple levels. And tobacco is a good example of that. We have policies at the federal level through FDA's regulatory authority. We also have states that are not preempted from acting at the state level and implementing policies. And also in many states, local action is not preempted. And it's this hallmark of tobacco control of policies that have been implemented at the local, state, and level that have ultimately helped to drive awareness of the risks of tobacco product use, but also importantly, those policies that we know work. And we also know that there's an added effect of locally salient work. And so I can't reinforce the importance of these, local level efforts and targeted science as well. And a good example is the approach to increase the age of sale for tobacco product use to 21. This happened in 2019. And at that time, it was a new concept for many people federally, but it actually started in the early 90s in Needham, Massachusetts. And also in New York City was the first bigger city to do it in 2013. And then you started seeing states doing it in 2015. And then finally, we had a federal policy thereafter, which was championed in a bipartisan way by Mitch McConnell and Tim Kaine. And ultimately, what drove this was that science and that evidence. At that local level, we showed that it worked. It was proven and tested. It was expanded. We got population level awareness. And as things continued to be evaluated, you built that evidence to ultimately get a federal policy that protected all Americans. And so ultimately, this is an important example of how we use the science at different levels to inform effective policy change. That said, now more than ever, we need tobacco prevention and control work in science. We've had impact at agencies as a result of federal cuts, including at CDC, the elimination of CDC's Office on Smoking and Health, which fields the National Youth Tobacco Survey. They do the nation's Tips from Former Smokers campaign that has helped over 1 million smokers quit. And they ultimately fund work at the state and local level to implement policies that we know work to prevent and reduce tobacco use. And so with the elimination of CDC's Office on Smoking and Health, we've lost that key conduit to translate that science and help states implement policies that we know work. We've also seen cuts from staff, including scientists at FDA's Center for Tobacco Products, which inhibits the ability to review applications for tobacco products and effectively use that to inform regulation. And also at NIH, we've seen cuts to many grants, including those in tobacco regulatory science, that again are helping to document risks, but also those interventions that we know work. And so now more than ever, we shouldn't be pushing our foot off the gas. It's pushing it down to make sure we're continuing to reduce what continues to be the leading cause of preventable disease and death in this country. So with that, I will thank you and appreciate the opportunity. If you're interested in more information, you can contact tobaccofreekids.org and look at some of our social media handles for a variety of scientific information that we use to effectuate change as part of our important work. Thanks for your time today.
Thank you so much, Dr. King. Next up, we have Dr. Namey. Dr. Namey is a physician and epidemiologist currently serving as director of the Canadian Institute for Substance Use Research and professor in the School of Public Health and Social Policy at the University of Victoria. He has trained at Harvard, UMass, and Massachusetts General Hospital, completed the CDC's Epidemic Intelligence Service Program, and has held positions with the U.S. Indian Health Service, the alcohol team at CDC, and Boston University School of Public Health and Medicine. His research focuses on alcohol and epidemiology, the health effects of substance use, and the impact of alcohol and cannabis policy. Please welcome Dr. Namey.
Oh, thanks for having me, Paige, and thanks to everyone for presenting. This is very bad following Brian King, and I like to think that he's going to represent the sort of the top end of the speaking spectrum, and I'm going to sort of show you the sort of a more lower bounds. But anyways, it was really nice. As Paige mentioned, I'm Tim Namey. I'm a physician and a substance use epidemiologist and policy researcher. And currently, I'm the director of the Canadian Institute for Substance Use in Victoria, British Columbia. And rather than tell you about the importance of federal support for research on substance use and addiction from the third person perspective, I'm going to try something a little different compared to what I do normally. And that is that I'm going to tell you a bit of a story through the lens of my own career and let you draw your own conclusions. Is it a cautionary tale? What does it mean? But after medical school and my residency at Mass General Hospital in Boston, I began my career in federal service working as a physician with the Indian Health Service in Zuni, New Mexico. It was an amazing time in my life, living in a wonderful community under the endless skies of Western New Mexico. I had a primary care practice consisting of my regular patients, and when I was on call, I covered the emergency room and the inpatient ward. As I always say, it was the best clinical job I could have ever wanted or asked for. But I was always interested in the bigger picture of well-being and in ways to protect people from preventable health and social problems. As it turned out, though, being a federal physician and a member of the U.S. Public Health Service facilitated my transition to a career in epidemiology and policy research. For me, that began with the Centers for Disease Control and Prevention, the CDC, through a training program called the Epidemic Intelligence Service. And I always like to say, I'm living proof that you don't have to be intelligent to have done the EIS program. Anyways, I was based in St. Paul at the Minnesota Department of Health. And I covered at that time all sorts of outbreaks of emerging infectious diseases. And while there, I am proud to say that I helped sort of crack the code to prove how new strains of resistant staph bacteria were, for the first time, infecting healthy young adults and children across the upper Midwest and ultimately across the globe. In 2001, I came to CDC headquarters in Atlanta to do further training in preventive medicine. Obviously, I needed more help. And it was there that I met Bob Brewer, and I will always be proud of my role as a junior partner in co-founding CDC's alcohol team, or the A team, as we like to call it. I worked with multiple national surveys like the Youth Risk Behavior Survey and the Behavioral Risk Factor Surveillance System. With those surveys, our focus was on binge drinking, or the pattern of alcohol consumption that leads to acute impairment. And in some ways, binge drinking is the fundamental building block of most alcohol-related problems. It causes lots of problems directly, but is also a risk factor for a lot of other problems, including alcohol use disorder itself. We published pretty influential papers that conservatively estimated that there were 1.5 billion binge drinking episodes annually in the US, that they typically involved 6 to 8 drinks, and that almost 1 in 10 episodes involved driving a car during or within a couple of hours of that drinking occasion. We launched the alcohol-related disease impact software application, or I don't know what you call it, to calculate alcohol-caused death by US state, and we tallied causes and effects from acute causes stemming from impairment versus chronic alcohol-related causes such as cancers, heart disease, and gastrointestinal diseases. We also worked on estimates of alcohol-related costs. And did you know that each drink sold in the US racks up about $2 per drink in costs, much of which is borne by the taxpayer and not the drinker him or herself? Since these costs greatly outweigh alcohol's meager tax revenue, alcohol consumption, and particularly that of heavy drinkers, is unwittingly subsidized by the public, many of whom also suffer its consequences through its secondhand harms. We also published a series of structured scientific reviews of alcohol policy evidence for the Guide to Community Preventive Services. This provided evidence to prioritize what works in alcohol policy, reviews on topics like alcohol taxes, the density of liquor stores, and the effects of reduced opening hours or closing hours for bars. The next chapter in my story is about NIH-funded research that I conducted while I was at Boston University and Boston Medical Center. I left the umbrella of federal employment. And that's really where I shifted towards policy studies. My research team developed a new alcohol policy scale for states based on 29 policies. And Tom Babor, who's familiar to many of you, and Tracy Toomey, who's here today, were involved in our expert advisory panel to help develop those scales. Our research showed that stronger policy environments, like, Rob was talking about, it's the environment, stupid, are associated with reduced binge drinking. He didn't say stupid, I did. Youth drinking and alcohol-related motor vehicle crashes and liver cirrhosis mortality, to name a few. What was really interesting was the consistency of the effect of stronger policy environments. A 10% increase in the restrictiveness of policies was associated with about an 8 to 10% reduction in all those negative outcomes across the board. We also found that those with alcohol use disorder who lived in states with stronger alcohol policies were more likely to be in remission 5 years later. We developed a similar policy scale for cannabis, along with a variety of smart folks, including Jonathan Calkins, who's testifying here today. The bottom line there is that it doesn't appear that the liberalization of cannabis policies has decreased the involvement of alcohol in violent deaths or motor vehicle crash fatalities, nor of opioid involvement in suicides or deaths of undetermined intent. This is a really important area of research that is ongoing and important. While at Boston University, I also collaborated with Dr. Siegel and Jernigan, who may be familiar to many of you, on studies of alcohol advertising and youth drinking. By showing the very tight connection between programming viewed by specific youth, the advertising for alcohol products on that programming that they watched, and their likelihood of consuming those specific products, we demonstrated the influence of alcohol marketing with far more precision and validity compared to prior work. At the University of Victoria, I've continued to do hopefully important work that has been enabled by US federal funding. Some of that work was funded by Marissa Esser's team at CDC, where among other works, we did a study updating the number of alcohol-caused deaths in the US, which currently stands at approximately 170,000 per year. Of note, roughly 20% of deaths among working-age adults in the US stem from alcohol. Some of it involved NIH support for cannabis and alcohol policy studies, in particular working with Dr. David Kerr at Oregon State University on research showing that stronger state policies for alcohol and cannabis are associated with reduced alcohol, cannabis, and use among college students, respectively, and are protective for alcohol-related violence, including sexual assaults. I was also one of the scientists for the SAMHSA-funded Alcohol Intake and Health Study, convened by Rob Vincent. Thank you, Rob, which was commissioned in support of the U.S. dietary guidelines. In my opinion, this is the most comprehensive study of alcohol-related mortality risk by drinking level ever conducted in the United States. Among other notable findings, that even at 2 drinks per day on average for men, which would constitute the upper limit of consumption based on the previous dietary guidelines, there is a 4% risk of dying from alcohol among men. All right. Well, as I survey the arc of my career, I unfortunately see major losses that feel very personal to me, but more importantly, that have large negative consequences for the health and vitality of Americans. The EIS program that launched my career has been degraded, and the CDC alcohol team and CDC's world-renowned Office on Smoking and Health, as Dr. King mentioned, were both dissolved. NIAAA funding for alcohol policy studies, which was already pretty minimal, is in jeopardy. Perhaps not coincidentally, the industry has lobbied strongly against policy research. And why? Because alcohol policies are the main modifiable means to measurably reduce consumption and harms at the population level. But enacting the most effective policies means reduced alcohol sales and profits. Let's face it, the U.S. federal government has been and should be the leading source of leadership in substance use research and the go-to for credible scientific information about substance use prevention and policy. But this leadership and this ideal is very much in question. We need to better understand the determinants of substance use and patterns of use through robust investments in epidemiology. And we need policy research to understand their role in preventing health, social, and economic consequences caused by addictive substances and behaviors. That research should be conducted independent of industry influence. As much as the alcohol industry has the right to advertise and sell its products, so too does the American public deserve to know about the impacts of alcohol consumption or other substance use, and about how to prevent the suffering of individuals and the collateral damage to the public. As I wrap up my remarks, I've had a front row seat seeing substance use problems through my own family, peer networks, and my work as a physician. As a researcher, I grew to better understand those problems and how to reduce them using public health approaches. I sincerely hope that insights from other researchers will be supported in the future so that people, and communities can live happier, healthier, and more productive lives. Thank you so much for inviting me.
Thank you very much, Dr. Namey. That was excellent. Next up, our next panelist is Dr. Toomey. Dr. Toomey is a behavioral epidemiologist and expert in public health policy and substance use control. She directs both the Cannabis Research Center and the Alcohol Epidemiology Program at the University of Minnesota School of Public Health. Dr. Toomey is also deeply engaged in policy and community work, including serving on the Mothers Against Drunk Driving Board of Directors, as a consultant for the STOP Act, and as a co-chair of the advisory board for the U.S. Alcohol Policy Alliance. Thank you, Dr. Toomey.
Thank you so much. I'm so happy to be here this afternoon. I would like to talk a lot about cannabis policy and implementation and kind of where we're at with that research, but it's really informed by my long career in alcohol prevention, particularly looking at alcohol policies. When I started as the director of the Cannabis Research Center in the School of Public Health at the University of Minnesota in the fall of 2023, I was kind of a switch in my career from alcohol to cannabis, and I had to really do a deeper dive into the cannabis research literature. And I have to say that I was surprised that there was so much that we didn't know. There's a lot of research happening, but there's still so much need for more research to better understand what are the potential positive and negative effects of cannabis, and how does it vary by the different types of products that are out there, as well as what is the full effect of legalization of cannabis across so many of our states. We also need to know what are the best prevention strategies. What's going to be most effective for preventing any problems that do appear because of cannabis legalization? And we also need to better understand what are the best treatment strategies for cannabis use disorder, which may be different than other substance use disorders. One of the challenges of doing cannabis research is that cannabis, of course, is a Schedule I drug, which is the most restrictive category of substances in the U.S. And it doesn't prevent all types of cannabis research. There's many things we can still do. But if we really want to understand this very specific effects of different cannabis products on specific health issues, it does place restrictions and limitations on what can be answered and how easily it can be answered. My focus in our center is really taking a public health approach, really using a cannabis policy lens. And this is very complicated. I think anytime we talk about substance use and policies, it's complicated. But coming from the alcohol policy field, I would say that cannabis is even more complicated. There are so many different types of products and ways of using cannabis. You know, people are smoking it, they're vaping it, they're eating it, they're drinking it, they're dabbing it. And the potency varies across products, and we really need to better understand what are the effects of the different types of products, different types of use, and the different levels of potency. Part of the challenge of doing work in this field is that there are really significant limitations in data sources. There's existing surveys that are out there at the national level, and many states have surveys. And historically, many of them, if they asked about marijuana or cannabis use, asked about cannabis use or marijuana use in the last 30 days or in their lifetime, and didn't ask about what products they're using and how they're using those products. We're seeing changes in some of those data sources, which is going to help us answer more questions. And there are centers like mine that are creating our own data sources, but it does, at the moment, limit what we can answer right now. Another challenge is that we have, ongoing changes to state policies. Currently, we have 24 policies that have 24 states that have legalized for adult use cannabis use, and many more that have a medical cannabis program. And we're seeing changes at the federal level. It appears that we may be moving towards rescheduling cannabis as a Schedule III drug, which will open the door for research and make it easier to do some types of research, but it doesn't solve all the problems of the limitations that we have on some types of cannabis research. And when we look at the state policies, there's ongoing lists of new states that are legalizing, but we also have to recognize that there's differences across states. And this is true for alcohol, this is true for tobacco, but it's so important that when we look at Minnesota and what happens in Minnesota, to recognize that it may be different than what's happening in California. And that's because there may be different types of restrictions or limitations on cannabis across the two different states. And one of the other challenges is that when a state legalizes adult cannabis use, there's a ramp up phase. So in Minnesota, for example, we became officially legal in the summer of 2023. And it's only in the last few months where we're seeing a growing number of dispensaries in our state. And so a reporter early on asked me, like, well, when are we going to know the effects of legalization in Minnesota? And I said, well, it's going to take a while. And she said, well, I'll get back to you in like 6 months. And I was like, no, it's going to take multiple years until all the dispensaries are open. And then we have enough data to look at what the effects are across outcomes. The good news, though, is as complicated as it is with cannabis, the good news is that we're not starting from scratch. We can absolutely draw upon the alcohol and tobacco policy research fields as well as the practice in both of those fields. Some lessons learned from my own career, and you've heard other presenters kind of touch on some of these topics today, is that we at least have some information on what might work for cannabis based on what works for alcohol and tobacco. First of all, I started my career focused on underage drinking. I as a PhD student, started working on 2 large community trials focused on preventing underage drinking. And I participated in systematic reviews of the research literature. And some of the conclusions that we have learned is that the age 21 minimum legal drinking age is effective. It helped drive down the drinking rates and the high risky drinking among youth in the United States. And so that's really important to recognize that we want to maintain that age 21 drinking age. We also learned that it wasn't sufficient. We needed additional interventions. And while many people are comfortable talking about school-based education programs and parent and caregiver programs, those are important. We want to have the best programs possible, but they're also not sufficient. We need additional policies at the institutional, local, and state level to reinforce the age 21 drinking age and enforcement of those policies to reduce access. We know that if young people can't obtain it, they can't drink it. Now, how does this apply to cannabis? Well, the good news is that all the states that have legalized have set an age 21 cannabis sales and use age. And that so far, I think, has been helping. We haven't seen a dramatic increase in use among youth following legalization. I worry, though, that as more states legalize and look away and don't, maintain the restrictions on access in their states, we may later see that increase in youth. And so, like with alcohol and tobacco, cannabis, we're going to have to keep our eyes on this and make sure that we continue to have those policies in place and active enforcement to restrict access to these products. Another lesson early on that I learned is that states and communities want to know what works. So my job was to go out and talk to the community groups, and they would say, well, what does the research show? What are the best strategies that they can use at the local level? And I have similar questions at the state level. So research is so important. Something else I learned early in my career is that doing alcohol policy legal research is very challenging. The first project that I managed, we were looking at the effects of changes in several types of alcohol policies over a 20-year time period. And we had to do original legal research retrospectively. And that was such a challenge. We thought it would take 6 months, and it took us 4 years. And so we can't have all the researchers spend 4 years developing measures of policy changes. That's just not cost effective. We also learned in this project that there was this great variability in the strength of policies across states. And this policy really informed the Alcohol Policy Information System, which is funded by the National Institute on Alcohol Abuse and Alcoholism. And it's a prospective tracking of alcohol policy changes over time and includes measures or component measures to measure the restrictiveness of or strength of those policies across states. And you already heard from Dr. Namey, who has used the Alcohol Policy Information System and created these scales to measure the strengths of combining policies across states and shown that stronger policies are more effective. And the good news is that APIS has expanded to include tracking of policy changes for cannabis as well as alcohol. And I'm assuming that Dr. Nemi also used that for his cannabis measure as well. And so having that type of infrastructure is so important. What are those tools that can facilitate really important research across researchers so that we're not all having to reinvent the wheel, and that we have the best data sources and tools to help us efficiently and effectively answer policy questions. I spent a lot of my career also focusing on the retail environment, preventing illegal sales to youth and obviously intoxicated patrons. And with youth, when we started doing this research, we found that 75 to 100% of licensed alcohol establishments would sell to someone that looked under the age of 21 without showing an ID. And we learned from research that there are strategies, specifically compliance checks, that are conducted regularly by law enforcement or licensing agencies. Going in and checking these establishments can drive down that likelihood of those illegal sales. And communities want to know, well, what's the most effective way to conduct those compliance checks? And so we need to continue to do research to give that information back to the communities. Minnesota has put a mandate in of 1 compliance check per year for the cannabis dispensaries and retailers in our state. And I'm not sure that's true in all states. And we want to make sure that we do the research to make sure that that's helping to secure our dispensaries and other licensed establishments so they're not selling cannabis to underage people. In Minnesota, before the system was put into place, we had many establishments selling hemp-derived cannabis products. And my former PhD student, Dr. Eileen Delahanty, did a study and found that 56% of the time, these establishments would sell to someone that didn't have an ID on them, that looked underage. And this was despite Minnesota having an age restriction on these products. So we need to continue to do research in this area. The 4Ps, product, placement, price, promotion. You already heard from Dr. King and Dr. Namia touching on that. Price is so important for alcohol and tobacco. The more expensive it is, the less consumption and less problems we experience. And we certainly can also look at product placement and promotion. And that's an area that we will need to look at for cannabis as well. This leads me to the Cannabis Research Center. We are funded through a state appropriation. And I will tell you that as a longtime NIH researcher, I feel very fortunate that right now we have this appropriation. It gives us such nimbleness. We can find out what are the research questions and launch research studies very quickly. Throughout my career, I would try to talk with people in the community and, and state agencies, local agencies, and they would ask me questions. And I'd say, well, I'll try to get funding. It might take me 2 years to get funding because it's hard to get policy research funded. And then, a few years after that, maybe I have an answer for you. With this funding, it just shows me the real great advantage of having money that is quickly accessible to answer the pressing questions that we have right now. So we're giving direct feedback about implementation questions as Minnesota is ramping up the legalization of the dispensaries and rolling out those dispensaries and other retailers. And we're doing a range of other types of research to answer a whole range of different types of questions and trying to do it as quickly as we can for our state. I think it's really important that we think about what are the needs, what are the questions, how do we find out what questions legislators, practitioners, and public want answered and get that back to them in a timely way. So it goes back to having the infrastructure in place to give timely funding to researchers and make it easier to get funding for policy research. A lot of the review groups don't understand the research designs that are needed to do policy research. And I think as we move forward, we can improve that and find ways to have more timely funding to get to research and make sure that we do more than just publish in peer-reviewed research studies. So we have to figure out the best ways to disseminate and reward that dissemination process that's outside of the peer-reviewed literature so that we get the research out into the practice and out to the elected officials who are making key decisions, who want to make decisions based on research. And with that, I'll just thank you so much and be happy to answer questions at the end of this, at the end of the presentations.
Thank you so much, Dr. Toomey. For our next panelist, we have Dr. Calkins. Dr. Calkins is a professor at Stieber University and Carnegie Mellon University, as well as a member of the National Academy of Engineering. He specializes in systems analysis of illegal markets with a focus on drugs, crime, and prevention, including opioid markets and cannabis legalization. Please join me in welcoming Dr. Calkins.
Good afternoon, and thank you very much for that introduction, Paige. I really appreciate and an honor to have the chance to speak today. The theme, of course, is evidence produces insight. And I'm going to illustrate that by example for evidence about markets and supply, and particularly illegal markets and supply. Now, Dr. Toomey talked about cannabis. I'm going to emphasize opioids. I will lead up to the Science article from last month that provides an explanation for the abrupt and wonderful decline in opioid-related deaths. 50,000 people are not dead today because of that change, but I want to set the stage. And here is a graph that attempts to do that by just plotting over time data on the number of Americans who initiated heroin, moved into heroin markets. And if you start on the left, you see a big bump there. That's the original heroin epidemic of the late 60s and early 70s associated with Vietnam War time, which was brought to a close by a few supply shocks that ushered in an approximately 20-year period of stability. It's not that heroin went away, but those markets were relatively stable until you see a second big spike, even bigger. That second spike is associated with the effects of liberal prescribing of prescription opioids, which developed opioid use disorder in a large number of people who would trade down to the illegal markets. And one of the insights from this chart is that that trading down, that entrance into the heroin market began before the restrictions on prescription opioids. And not only did that later era have a surge in the numbers of people initiating, but it was also a very different character. So this chart is just plotting what proportion of these people entering into the heroin markets had previously misused prescription opioids. And in that long period of stability, it was certainly not zero, it's a third or 40% or so. But you can see that as prescription opioid prescribing grew, by 2012, it was fully 80% of the people moving into the illegal opioid markets who had previously misused prescription opioids. And this slide shows a similarly dramatic change in the age composition of who it was who was entering into heroin markets. Back in that earlier period of the 70s and 80s, it was almost entirely people who were relatively young, troubled youth, disadvantaged backgrounds, escalating up through a sequence of what you might call recreational drugs. But in this later time period, very different. You have a large number of people over age 30 and over age 40 using heroin for the first time because they got there via the vector of prescription opioids. So this sort of sets the stage for the fentanyl crisis because we built up a pool of 2 or 3 million people with opioid use disorder, far more than we had in that earlier era. And there were increases in heroin overdose in that 2010 to 2015 time period. But of course, opioid overdose deaths really exploded with the transition of the markets to fentanyl. And again, data and evidence can explain why. And this slide's got a lot of numbers on it, so let me just tell the story, which is if you put yourself in the shoes of that high-level kingpin of a Mexican drug trafficking organization back in 2015, you had the opportunity to radically reduce your raw materials costs because synthetic fentanyl came on the scene that was less expensive per kilogram than crop-based heroin, and it packed 20 or 25 times as many doses per kilogram. So the price per dose was just radically lower. And so for the first time, we have a drug epidemic, this fentanyl epidemic, that wasn't a viral spread person to person on the user side. This was a sort of strategic decision from the drug kingpins. It radically reduced their production cost. Initially, that translates into higher profit for them, but over time, competition in the marketplace pushes down prices throughout the supply chain, even down to prices that individuals on the street are paying. And here, unfortunately, I'm not able to show US data on the retail prices because whereas at one time we led the world in monitoring our illegal drug market prices, we stopped funding that around 2016. So I'm going north of the border to Dr. Namey's territory. These are Canadian data because Canada has better data on prices. A lot of numbers on the slide. Don't worry about most of them. Just look at the two that are circled in red. So the top one says that back in that traditional heroin era, the price per MME, it stands for morphine milligram equivalent. It's just a common unit for comparing prices across opioids. So the price was 13 cents per MME, and then that lower red circled number says in the fentanyl era that had fallen below 2 cents per MME. And that's even before adjusting for inflation. When you adjust for inflation, you have about a 90% decline in the price per unit of illegal opioid. And as Dr. King said with tobacco, prices matter, and they matter for addictive substances, legal and illegal. Now, admittedly, this slide's pretty complicated, and I apologize for that. But what it is showing is that depending on price, or more generally supply and availability, people who have opioid use disorder use radically different amounts per day. So intensity of use is highly responsive to changes in price. Down here in the lower left, which is a classic heroin market when supply is tight, it might only be 100 MME per day. In a standard heroin market back in the day with typical supply, you're in the 200 to 600 MME. When the heroin is free to the person, as in heroin-assisted treatment, you can be in the 1,000 to 1,500 MME per day. And in fentanyl markets today, it can be 2,500 or 3,000 MME per day. So this is a way of saying price matters. When price goes down, consumption per person per day goes way up. That has all sorts of consequences. It means, for instance, takes more naloxone doses to recover from an overdose. It means that diversion exposes opioid naive people to larger quantities and so on. Yeah, that's the setup. We developed a lot of people with opioid use disorder, and there was for a long time very abundant supply. The result of that was massive ongoing increases in overdose death. In fact, there was this article also published in Science, quite famous, that said this exponential growth in death has just been going on for 40 years. We cannot imagine anything stopping it. And in fact, if you asked any of us in April of 2023, do you think that this is going to drop by 50% in the next 2 years? We would have said Ice Cube's chance in Hades. It would have been like standing in Berlin in 1988 and saying, what do you think are the chances this wall is going to come down? But it came down, and it came down a lot and fairly abruptly in third quarter of 2023. This graph is just juxtaposing the decline in overdose deaths with decline in conventional measures of illegal supply, that is purity, seizures, and so on. And we can corroborate that with some more creative measures of supply. So the PhD student in this project went off and went to the R-fentanyl subreddit and gathered data on how often those individuals were referring to droughts. And you can see where there is this massive increase in chatter about droughts at the same time, droughts in supply at the same time that overdoses dropped. So much so that you see this gap here. That's the moderators on Reddit saying, hey, cut it out, guys. We're going to ban all reference to droughts because they were concerned that Reddit was being used to describe how people could acquire them. So radical change in the marketplace in the United States, reductions in supply and death at the same time. And the second half of the article was to look north of the border, in Dr. Namey's territory, and recognize exactly the same kind of patterns in Canada. Fentanyl deaths in Canada and the United States started up around the same time. They increased at about the same rate. Ballpark, they reached the same peak. Ballpark, they started to come down at the same time. And Canadian supply indicators also started to come down at the same time. And so then the really interesting question is, well, how can that be? Two countries with radically different policies, even when they do the same policy, they don't deploy them at the same time. How could there be these strong parallels? And that's an active question that we hope more research can be done on. But of course, the provocative conjecture is to go back to at what point do those two countries' fentanyl supply chains intersect? Because illegal fentanyl consumed in the United States is manufactured mostly in Mexico. Illegal fentanyl consumed in Canada these days is mostly produced in Canada, but in both cases produced with precursors that come from China. So that raises the very interesting possibility that it was events in China that played at least an important role in creating the supply shortage in both Canada and the United States that has us with, as I said, about 50,000 people who are with us today who would otherwise have been dead had the patterns continued as they were. So I hope this is an illustration that looking at supply indicators can provide insight. The sad part of this story is that while the United States once led the world in scientific research of illegal drug supply, we now lag badly. We've undermined the data collection and restricted its sharing. And so it's much harder for us to do this kind of work than it used to be. So thank you very much for the opportunity to present this information.
Thank you very much, Dr. Calkins. Finally, I'd like to introduce our final panelist, Dr. Green. Dr. Green is an epidemiologist whose research focuses on drug use, opioid use disorder, and drug-related injuries. She holds a PhD in epidemiology from Yale and serves as professor and director of the Opioid Policy Research Collaborative at Brandeis University, where her work centers on the drug supply, overdose prevention, and risk mitigation. She also co-directs the Center of Biomedical Research Excellence on Opioids and Overdose at Rhode Island Hospital and Brown University of Medicine. Please welcome Dr. Green.
Thank you so much, Paige, and thank you for the invitation to be here today. It's wonderful to be amongst colleagues and looking forward to discussion after this last presentation. So first, though, to ground this conversation, allow me to take a step back into our common history. This a portion of this may be familiar because it was part of John's last presentation, but here, our common history as the unfolding of the current opioid crisis has been said to resemble three waves defined by opioid type: prescription opioids for pain, heroin, and synthetic opioids. Now, despite the use of opiates as far back as Neolithic times, a major gap in these early waves was that we really didn't know much about opioids, about chronic pain, about fentanyl, let alone overdose. In fact, it wasn't until 2011 that federal agencies used the term epidemic alongside overdose, and until 2018 that federal research agencies considered overdose as an outcome of interest to study and not just an adverse event. So research to fill these knowledge gaps was and continues to be critical so we can better mount effective response and move data to action. Now, we've learned a lot and fast. While there are many responses to address opioids, I will focus on a few that are evidence-based ones that I can speak to. There really is no more profound data to action story in the opioid crisis than that of naloxone, the opioid overdose antidote. FDA approved in 1971 for use in the pre-hospital settings to diagnose and treat respiratory depression caused by opioids. Naloxone is the go-to medication in an overdose involving any opioid, including those synthetic ones we have yet to even meet. But as a prescribed medication, the paradigm really needed to shift from a prescription-focused medicine to a layperson-administered medication. Building the evidence base around safety and feasibility to do so is part of what you see here. Through community researcher partnerships and tireless, and underfunded studies conducted through brute force and deep community devotion, this cascade of evaluations conveys some of the early documentation of naloxone's promise. Like many of my research mentors and peers when in school, we cut our teeth and rose up the research ranks during another earlier challenging health epidemic, HIV and AIDS. Activism, centering patient voices, meeting with policymakers, demanding and dedicated research funds and expedited drug reviews, as well as outstanding science, led to massive headway on HIV/AIDS, the momentum of which continues today. Taking this energy and partnership into the opioid crisis, we expected listening to and making space for community leaders and ensuring community engagement in that data to action. And it worked. All states have adopted naloxone access laws, allowing people to obtain, carry, administer a prescribed medication to other people, naloxone. And that is if someone is overdosing. Federal action in 2018 adopted the universal precaution of co-prescribing naloxone to patients at high risk of overdose. And finally, in 2023, we saw the approval of over-the-counter naloxone and sales at a pharmacy near you. With few restrictions on its prescription status and a community-grounded orientation, naloxone access innovations allow for naloxone in places, not just to people, and extend the reach, hours, and normalization of this life-saving medication. But just how much naloxone do we need in the community to save lives? Using mathematical modeling, our research results showed just how much naloxone each state needs to reach saturation, providing policy-relevant targets for state planning and funding. But we must recognize the enormous toll of human life that this reflects as the impact of the opioid crisis crosses party lines, geographies, and demographics. Naloxone centers us in the fundamental human act of saving another person's life. But what were some other things we could do? Well, a helpful data nudge came from ambitious efforts to leverage big data initiatives. And for this, it doesn't get more rich than the public health data warehouse of the great state of Massachusetts. Here, the story was really a loop: policy action to data, back to policy action, in a legislatively mandated population level data linkage across multiple data sets to drill down and answer big questions. This one by Mark LaRochelle and colleagues asked, what are high yield opportunities to deliver services that can reduce overdose and boost treatment starts? What are the places in the system, the touch points, where we have a chance to intervene and shift mortality risk? Touch points like non-fatal overdose event and release from incarceration pointed the way for policymakers. In Rhode Island, where I spent a good bit of my time, it had the 5th highest drug overdose rate in the country. Action took the form of an executive order from the governor, charging me and my colleagues to craft a strategic plan in 90 days that was evidence-based, with the goal of reducing deaths by 1/3 in 3 years. So topping our list of effective interventions was broad expansion of MAT, medications for addiction treatment. After all, it's been shown to reduce overdose mortality by half. And Rhode Island's tough on crime approach had really mushroomed the incarceration population, providing really clear rationale for a targeted investment in a statewide MAT program in corrections. And that's what the governor got behind. That's what the legislature supported and the good people of Rhode Island invested in, building the first statewide program of MAT in corrections in the country. In an aggressive 9-month rollout of all 3 FDA-approved medications for treatment of opioid use disorder across all facilities led to a very different outcome, and in short order. Despite rising fentanyl levels in the community, we saw a reduction of overdose deaths post-incarceration, and subsequent modeling work extended these findings to land at a 31.6 reduction in overdose deaths for those with a prior year incarceration. They say, bad news travels. Turns out good news transforms. This high-value, life-saving idea led to hundreds of facilities introducing MAT in jails and prisons across the country, with more statewide programs like Rhode Island being adopted. And you can check for where you live at the prisonopioidproject.org website that's listed there, and hopefully check in later. But more needs to be done, because at that broader community level, medication treatment is woefully inadequate, severely deficient compared to our peer countries. Only 11% of people with high-risk opioid use or with opioid use disorder receive medication treatment. We are at the bottom of this chart. So if every prescription needs a pharmacy to fill it, what if you could get addiction care directly at the pharmacy? Pharmacies are ubiquitous. They can offer many services, are uniquely community embedded, and pharmacists are totally underutilized as trained health professionals. So that's what we did in Rhode Island. We built, trained, and tested a pharmacy addiction care model offering withdrawal supports, buprenorphine induction, on-site and ongoing care options, all right in the pharmacy. And we found rates of engagement after induction of 89% at the pharmacy compared to 17% in usual care. Pharmacists can and want to do this. And it turns out pharmacists also are keen to provide methadone in this environment. And this nifty return on investment analysis shows that if they do so, it's profitable too. To translate these ideas into actionable next steps, we generated toolkits, websites, policy memos, and legal guides, including model language to facilitate shifting data to action. Check out the pharmacybridge.org website and the QR code for details. But in the era of synthetics, naloxone and medication treatment, while evidence-based, are not enough, bringing us back to the 3 waves. Deaths in 1 year exceeded those of all armed conflicts since World War II. 1 year. If not for COVID, this crisis would be our defining epidemic. And here, detecting fentanyl was hard. We really needed to change that. We cannot see fentanyl. How can we shift risk behaviors, improve treatment, let alone change policy? So in 2017, at the base of that fentanyl peak, back in Rhode Island, in a study that partnered community programs in Boston, Providence, and Baltimore, and the police crime labs in the cities of Baltimore and Providence, we tested out test strips using standard laboratory testing and subjected the strips to real-world drug samples. Our findings showed that they were highly accurate tools, could detect very low levels of fentanyl, and with training could be used by anyone, just like naloxone. The following summer, fentanyl test strips were legalized in Rhode Island based on these data, and unfortunately, the absolutely unacceptable loss of human life in the Rhode Island communities. The ability to detect, avoid, and reduce risk of fentanyl with these test strips puts a new power of prevention in the hands of the community. A few years later, after more data cataloged test strips as tools for community education and engagement, as well as detection, CDC, SAMHSA, and the Office of National Drug Control Policy took the bold measure of conveying permission to use federal funds to purchase test strips. This was a major policy advancement. Today, all but a handful of states have decriminalized test strips. And this data to action happened just in time as the fentanyl era is evolving again. Tools like test strips and more comprehensive drug checking can more readily be used. New phenomena can be studied and findings more quickly translated into policy recommendations, as occurred in an epidemiologic investigation that Massachusetts and the CDC engaged in. Dr. Howry spoke to this actually in the first session. And that was set to understand the veterinary sedative xylazine that we kept finding in the Massachusetts drug supply. Now, we're seeing a big decrease in overdoses, as Dr. Colgan spoke of. So what's next? Are reductions in overdose a triumph, a respite? In a toxic, unregulated drug supply, we need to be attentive through research to people's experiences, their bodies, their drugs. We also need to be flexible in conducting research and also in our policy responses. This female from Boston that I met while doing the xylazine interviews reminds us of the profound loss that the survivors of these waves have been experiencing. If we do indeed see fewer deaths, we need to make sure to continue to see, call out, and work to reduce the suffering. With gratitude to our current grant funding agencies and past grant agencies, as well as my colleagues in Rhode Island, Massachusetts, the health departments there, and the communities that have helped us a long way. Thank you very much.
Thank you so much, Dr. Green, and thank you all for the rest of our panelists. We've just heard a fantastic set of perspectives on alcohol, cannabis, opioids, and the broader public health policy and the critical importance of sustained scientific funding in these areas. I'll now hand things over to Denny, who will be moderating our question and answer section.
Thank you, Paige, and to all of our speakers. That was truly incredibly informative and instructive with respect to how to move forward with this important research that you all have been involved with that has, immediate implications for public health policy. I think if we didn't have access to the data that research is producing that you all have been talking about, with respect to the causes, the trends, the patterns, the consequences of substance use in the United States, it would be so much harder to develop effective policies and interventions. All the public health officials, government, lawmakers, communities, we would lack the evidence that's needed to make informed decisions. We wouldn't know how to go forward. We wouldn't know what's working, what's not working, what not to invest in, as opposed to what is worthy, what is actually producing results. So, if we're able to continue, supporting the data infrastructure, the research, the grants, the investigators, the staff, the facilities, in order to continue to generate this information is absolutely critical to keep ourselves informed so that our policies can evolve in a way that is really evidence-based and evidence-informed. So I thank all of you. I thought it was absolutely terrific, every single one of you. There is just one question, but we can always find more questions. So I can come up with a few perhaps, or maybe you could ask each other. But I thought this was a very good question in the Q&A. This is for Dr. Toomey. Even within a state, there are major differences in local jurisdiction policies. For example, in California, Nearly half of localities do not allow legal sales. How do we move beyond binary yes, no analyses if state policies, it probably should be in state policies, right? Do we need to complement that with research on local policy environments, Tracy?
It's a terrific question. So we do know that there's great variability across states in terms of the state level policies for alcohol and cannabis, I assume also for tobacco, and there's varying degrees of local control. So for in Minnesota, for example, communities cannot ban dispensaries in their jurisdiction, which is different from what was just stated for California. And if you have a huge number of local jurisdiction banning dispensaries, that needs to be accounted for ideally in our state analyses. We do not have that I know of a tracking system for local level policies, at least for alcohol and cannabis. Um, uh, Dr. Tobin Nelson, who is at the University of Minnesota, he led a project where we were collecting local alcohol policy information and then looking at the level of control across local communities. And that was a massive undertaking to do that research. And so, yes, we should be focusing on the local level, and it is very difficult to do that. And I don't know, Tim, if you want to add anything, because you've also done a lot of work in this area.
No, I think I don't want to take. I think what you said is absolutely great. Nothing really to add to that. Thanks.
Okay, very good. I do see more questions in the chat. I found them. Becky, who is from Nairobi, Kenya, recently the legal drinking age was set at 21. What are the parameters to ensure it's working? Because recent data shows there's increased alcohol addiction at the university, yet majority of students are below 21. They will send their peers to buy on their behalf. How does it work over there? Brian, do you have a response to that, perhaps?
Yeah, sure. So I'm happy to speak from the tobacco paradigm, and it ultimately comes down to two key things, education and enforcement. And so ultimately, with these types of policies, it's important to educate from the get-go, including the general public, but also those responsible for implementing. And so typically with the rollout of increase of age of sale policies, including the federal increase to 21, there was a coordinated effort to educate the public about this, but also importantly, to educate retailers and others who are in charge of implementing it. That said, you also need enforcement teeth. A policy is only as effective as its ability to be enforced. And federally, when it comes to tobacco, the Tobacco 21 policy is enforced both federally, but also at the state level. And there are coordinated inspections that happen at the local and state level on a routine basis to assess retailers, and then also to take appropriate action as needed, which if there's enough violations, that could include removing their ability to sell the products altogether. Ultimately, punitive actions against the retailers are preferred against users, particularly underage individuals. And that's the paradigm that's worked effectively for tobacco to monitor the issue, but also to take action to prevent any recurrence.
Sure. Tim, did you have anything to add to that?
Yeah, and I'm sure I'll call out Tracy too, but yeah, in everything I agree with what Dr. King has said. I think, but I do think that there's in using the alcohol example that there's a lot of impact of policies even in the absence of really good enforcement. I will use alcohol as an example of that. They're not nearly the same rate of compliance checking that we see with tobacco, and yet the implementation of age 21 MLDA laws in the US has been very impactful. That's not to say that when you say, well, of course, kids are still drinking. Yes, that's it. Nothing by itself is crucial. But I think the fact is that a lot of people or their parents or people who purchase for them don't like doing illegal things. And I think age restrictions have a strong track record of evidence, at least in sort of middle and higher income countries.
Can I just add one thing? I think the retail environment is so important to look at, and that is where a lot of the flow of alcohol and other substances will come from. But I think you need to go in any community or any state or any country, you need to look at where underage people are getting the substance that you're focusing on, and then look at what is the best strategy to cut off that particular source or the most common sources. And sometimes it will be retailers, and sometimes it's going to be parents or guardians, and sometimes it's going to be friends. And we don't always have the answer, but you have to think, what is the specific strategy for what you are dealing with in terms of access points?
Mhm. There is another question for you, Tracy, in the chat. Could you please characterize the debate at the state level concerning marijuana prices, parallel or not to alcohol taxation?
It's a good question. I don't know if I have a good answer. Truthfully, I think we're still learning so much with cannabis. I just, was looking at, I was reading something about taxes on cannabis, and there's just not as much literature as we do have for alcohol and tobacco. And it's a real challenge when you think about the price of cannabis in the dispensaries, and you got to be really careful as we put a tax on it that we don't drive people into the illicit market. And so there's a balancing act that a lot of states are having. And I don't have an answer, but we need, other than to say we need more research to better understand that. And it looks like Jonathan is going to add something.
Yeah, I mean, one of the phenomenon is that the price per milligram of THC has dropped by 90% with legalization. And a lot of the taxes are ad valorem, a percentage of value. So when the price drops 90%, the effective tax also drops. So that's one of the challenges on the cannabis side.
Okay, something else just popped. Let's see. I don't think it's a question. Wisconsin law allows kids under 21, if they're with their parents, guardians, or spouses of legal drinking age, to consume alcohol. And if the establishment allows it, do you think this law should be repeated, as it would be an onset to further problems? Anybody? That's a wild law.
Well, one thing I can say is when we talk about the minimum legal drinking age in the US, it's variable across states. So there's age 21 is the limit, and there's a long history with the drinking age in the US. But there are loopholes, and the loopholes vary across states. And so Wisconsin's has got one of the bigger loopholes that is described here. There's others that have bigger loopholes. So when we look at the effect of the minimum legal drinking age across states, this is an example of something that we have to factor in. Now, should it be repealed? I think in Wisconsin, if I were doing research, it would be looking at, how big of a source of alcohol does this loophole allow, and is that contributing to some of the problems? And if it is, then that may be something that should be repealed.
Right. Again, data so essential to knowing what the consequences are, just as it is for legalization of recreational marijuana. Not only, what are some of the consequences for adults, but what are the reverberating effects on adolescent use? The reduction in beliefs about the negative consequences of cannabis use during adolescence declines, which is directly inversely related to an increase in cannabis use in adolescence. And so there are a lot of these reverberating effects that make it so vital that we have access to these data. Do you have any questions amongst yourselves?
Well, I was just wondering, Tim, the work you've been doing for alcohol and cannabis about the strength of the policies, this loophole question is kind of related to that. And I don't know if you maybe want to add to that, because I think it's so important for as states are trying to think about what they can do.
Yeah, we haven't studied that specific loophole, right? But I do think you're right that the local context matters a lot, and how much youth drinking is out happening in licensed establishment with their parents. I don't know. I don't suspect it's like a huge amount, but that sort of loophole may reflect a local culture. I mean, I think Wisconsin traditionally is one of the sort of the states that is a traditional leader in binge drinking. So I think there's a very strong sort of alcohol. So you have to also, one of the challenges, Tracy, as you know, is how we separate the sort of local culture that may generate the adoption of policies or not, and the effect of those policies. So this may be one where it's more a reflection of the drinking culture in Wisconsin than in terms of its actual impact on the ground. I don't know.
Yeah, a question for Tracy. I was surprised to learn from Jonathan about the change in the availability of fentanyl from China. But I had attributed a lot of the decline in opioid use to the availability of Narcan. But to what extent do you think that played a role?
When it comes to the synthetic era, it's really driven a lot by the supply. And we've adapted as humans and through our research to understand that these tools of prevention and response need to be as close as possible, as readily available as possible. So naloxone has been huge across the board for any opioid, but we used to have to prescribe it and pick it up here, and it was only limited to some people. Now, the idea and the change in adaptation to what it means to have a fentanyl crisis is you have naloxone in your pocket. You have it in your space. You have it probably in multiple places in your room if you have someone that you love who's using opioids. So those adaptations, naloxone has a huge component to it, but they're almost intertwined with the supply. Plus, we have some opportunity to invest in research to understand these things in the future, and hopefully the future will be able to provide insights into how much we might be able to contribute to our policy decisions, our international diplomacy, other actions, and our community responses. But they are intertwined very much in the fentanyl crisis.
Yeah. Yeah, I think sometimes maybe the general public, whoever, conflates the rates of opioid overdose with the misuse of opioids. Has the misuse declined commensurate with a decline in overdose? No, Jonathan says.
No, so the onset of the fentanyl crisis was not a big increase in the number of people with opioid use disorder accessing illegal opioids. It was a massive increase in the death rate per person year participating in those markets. And likewise, the good news of the last 24 months is probably primarily a decline in the death rate per person year in those markets. There might be some reduction in the number of people participating in those markets, but the big movements are in death rate per person year of exposure. And again, that's what makes the fentanyl thing different. Like if you go back to the cocaine epidemic, when you saw cocaine overdoses soaring, that was because there was a soaring number of people who were using cocaine in uncontrolled ways. But these fluctuations in deaths are quite different than fluctuations in the number of people with opioid use disorder, which don't move up and down anywhere near that fast.
Yeah. So that's very important for the public and policymakers to understand, and it draws attention to the absolute critical need for prevention of substance use at the outset.
Yeah. And also to pick up on the theme of data and data infrastructure, it means we want to have a lot of different ways of measuring the scale of the problem. In some respects, death is such a horrible thing that we almost have become too focused on death as if it's the only measure we need, and perhaps have underinvested in trying to monitor the number of people with opioid disorder, and for that matter, number of family members who are influenced by other people's opioid use disorder. Tracy, I was really glad to see you mention what you did, but we don't have national monitoring systems for how many people have a spouse whose substance use disorder is affecting them. And so I think more different indicators would be really helpful to complement, not just following death.
So build the infrastructure, don't reduce it ultimately. Tim?
Oh, I just had a question for the for my fellow panelists, or two actually, but I didn't want to jump, like if you've got other ones lined up in the queue.
No, so it's 3:30, but we can continue.
Oh, okay,
People are
yeah.
still on. No, people are still on, and I was also going to ask Rob if he wanted to say something in closing, but so go ahead. Go ahead, Tim.
Okay, let me see. So the decline in opioid overdose deaths. We heard from Jonathan about the role of prices or the drought, and I'm not sure if the prices have risen quite as high as the deaths have fallen. And we also heard from Tracy about naloxone. Are there other things? And can either of you talk about, like, if there's any role of social attitudes? We talk about stigma as being a negative thing, but let's say changing social attitudes or awareness of dangers of use. What are some of the other factors that may be in play that are kind of harder to measure?
Do you want to go first, Tracy, or?
Well, sure. I do think that a major mechanism of death is isolation, social and physical isolation, and unmonitored use. When it's potentially fentanyl, could mean that someone's not going to be found and therefore intervened upon. And so the idea and social isolation makes it harder for people to ask for help, to seek treatment, and to talk with other people that might be available. We know social support is preventative for substance misuse in the first place, but also for people who are affected to have a recovery journey that is that's different. So I think we're coming off of COVID, where we had the most profound physical isolation ever, and serious mental health concerns for across generations. So we may not be able to attribute it exclusively to these social factors, but they play a role, and they always have. And so I think we have a lot to spend time. This is why we also need our social scientists, not just our mathematicians and our epidemiologists and our doctors, the full spectrum. By the way, this is a huge pitch. We need young people. We need junior scientists. We need pipelines. We need training. We need our labs to exist so that we can mentor students. We are losing a generation if we do not invest in them. And I'm deeply worried about this. And in this session, I think, like, these are important questions, but we have to have the next generation around to ask them. And because we'll see something again in one of our areas of addiction: tobacco, alcohol, cannabis, or opioids. And we need that generation.
My comment is just everything you mentioned, no doubt matters. And even other things like the shift from injecting to smoking reduces number of deaths per person year of use. It's just, I don't think most of those sort of cultural changes, for a lack of a better word, happen abruptly. So they're there, they matter, but they're more like in the background trend. And also on top of that, superimposed on top of that, something happened in the latter part of 2023.
Yep.
Yeah. Excellent. Excellent conversation. Rob, did you want to say anything in closing?
Sure. Well, first of all, thank you. Many of my heroes and colleagues and friends are all here. So let me just say thank you for all of your brilliance and work. But what is currently happening, which has been echoed so many times, is the degradation of a system. And unfortunately, to Dr. Green's comment, but others as well, without pipelines, without the next generation, the question is not what the next substance use epidemic is. It'll just be what's the next drug. In 38 years, I've watched it just travel up and down, depending on, I'll call it drug du jour. Whatever was popular had access, but we are losing as a result of policy choices, the idea of evidence-based policy making, and the idea of making sure that we have a system that is preventative in nature, rather than waiting after the fact. And a friend and colleague of mine, Dr. Michael L. Dennis, often talks about that we could reduce up to 27 years off the substance use career if we can get ahead of it before 15. And when you add in the economic impacts, the societal impacts, the family impacts, that is really quite unfortunate, because that could be the difference between a research and going on to education or homelessness or all kinds of points in between. And so, I think our children deserve better. And I think, the more we can focus on things that work and lean into that and not disrupt the what has taken an awful long time to build, would be quite helpful to all of Americans, frankly. So, but thank you for that.
Yes, thank you, Rob. That was very poignant. Well, thank you all, and thanks those of you who stuck in there with us till 3:35. Really appreciate it. You'll receive a link to the recording and some resources and slides about a week after today. So thank you again. Keep your eyes out for the promise of prevention. We'll talk about making all of this go away. Take care, everybody. Thank you so much.